Hi everyone, this is Dr. Terri Messman Moore, and in this audio lecture I want to talk a little bit about somatic complaints and how somatic complaints are connected to psychological diagnoses. The focus of this video will discuss differential diagnosis and how we can make decisions where we separate fake behavior that is not related to a psychological diagnosis from fake behavior that is. So in this video, I want to talk about how we distinguish between three clusters of disorders. First, we have malingering. Malingering actually isn't a disorder in the DSM because it is just when people are faking it. So malingering is something that we want to know about and know how to assess it and make sure that we can distinguish it from actual psychological disorders. The second group of disorders is called factitious disorder, and this is generally separated into two categories: factitious disorder that is imposed on the self and factitious disorder that is imposed on another. And lastly, we have a larger group of disorders that are called the somatic symptom disorders. The primary somatic symptom disorders are illness anxiety disorder, otherwise known as hypochondriasis, somatic symptom disorder, and conversion disorder. So in this video, I'm going to focus on malingering and factitious disorder and touch on somatic symptom disorders, but we'll come back to that class of disorders and go into deeper or more detail later. All right, faking it. So faking it is really common. You may not be surprised by that. Faking it involves individuals who decide to engage in behavior for a particular reason, and it is intentional. In the psychology literature, we call this malingering. So it's really important for us to be able to distinguish between people who are malingering, who are faking it intentionally, and that from factitious disorder, where people are faking it intentionally but actually have a disorder. So again, malingering is where we see intentional faking of symptoms. Factitious disorder also involves intentional symptoms. And we have formally discussed this disorder in previous years as Munchausen syndrome. You can also have factitious disorder by proxy. You may have heard of Munchausen syndrome by proxy. And this is where there's an intentional production of symptoms in another person. Typically, the presentation for Munchausen syndrome by proxy is of a child who has an adult, usually a parent figure, who is intentionally producing symptoms. So what do we know about malingering? Malingering is connected to what is called secondary gain. Secondary gain is something that's happening outside of the person or the psyche. So with malingering, we tend to see scenarios where individuals are motivated to fake psychological or medical conditions in order to obtain something important to them. Usually these are material items such as money or particular, maybe we might look at like particular equipment or something like that. So the typical person who is malingering is faking a disease or a disorder in order to get a payoff. Sometimes what they're doing is trying to scam insurance companies. Sometimes what they're doing is trying to scam workman's compensation claims. Either way, they really are not experiencing any of the problems that they so-called have or what they're sharing or projecting out to the world. And the main reason they want to do it is to get money. So one of the things we're always doing when we assess for malingering is that we are going to do an assessment to determine the context in which the symptoms are occurring, the onset, and so on, and if it's connected to any secondary gain. In contrast, we have factitious disorder, which is imposed on the self In this case, we do see actual symptoms or signs of a disease or a disorder. With malingering, we're not really seeing a lot of evidence of the disease or the disorder, but factitious disorder is associated with symptoms. And these symptoms are typically very confusing to medical professionals because they don't always make sense. So cases of factitious disorder have really they've appeared in the medical literature a long, long time ago, as early as the time of Galen. And there's the term factitious is derived from a book by a physician named Gavin, which was published in 1843, and this was called On Feigned and Factitious Disorders. But really, the modern study of factitious disorder is credited to a psychiatrist from Britain. In the Lancet, he published an article in 1951, and his name was Richard Asher. And Richard Asher is also responsible for the term Munchausen syndrome, and he described Munchausen syndrome as a subtype, a chronic subtype of factitious disorder. So Munchausen syndrome comes from an 18th century German baron who liked to embellish stories of his military exploits in order to impress his listeners. So in 1977, Gellenberg, who first reported a case of factitious disorder with primarily psychological symptoms, factitious disorder was recognized as a formal diagnostic category in the DSM by 1980. Within more recent iterations, the factitious disorder is thought to have three subtypes: a primarily psychological subtype, a primarily physical subtype, and a combined subtype. So there's also a fourth syndrome known as Ganser syndrome, and this has been classified in the past as a form of factitious disorder, although the DSM-IV groups it with dissociative disorders. So one thing to remember is that dissociative disorders and factitious disorders and somatic symptom disorders tend to be connected through their connection with trauma, and we'll talk more about this another time. All right, so what are the symptoms or the criteria of factitious disorder? Well, the criteria are that the patient is intentionally producing or pretending to have physical or psychological symptoms or signs of an illness, and the patient's motivation is to assume the role of a sick person. In other words, they're motivated to get attention or compassion, or just being the center of attention, like in a very strange way, like perhaps having medical interns and individuals coming to look at them because their presentation is so unusual. So this really differs from malingering, where there's an external motivation that explains the behavior. So there's a lot of signs of factitious disorder. Remember, signs are things that are happening outside of the person, things that you can observe. So some of the signs of the disorder actually are not even things that we would see in the person's body, but it's really looking at the medical history of these individuals. So individuals with factitious disorder tend to seek a lot of medical care. When they do it, though, they have a very vague and inconsistent history. So in other words, they may not be very good at reporting their medical history, and they may have difficulty being specific about it. Despite this, they have a very long medical record. So what we tend to see with these individuals is that they are often admitted to hospitals. These are typically different hospitals, and this might be by design, right? If they are admitted to different hospitals, there's a less chance that this individual will be found out, right? Because there aren't going to be doctors who are familiar with the presentation or who have seen the patient. And also the records within hospitals are not always linked. And so that means that if someone comes into the hospital, your hospital, Hospital A, may not know that the patient has been admitted to Hospital B and Hospital C. Another thing that's really fascinating about this disorder is that these individuals tend to have a very unusual knowledge of medical terminology, and not surprisingly are employed in medical or hospital-related occupations. Now, we think that potentially they're employed in these settings in order to learn more about medicine and to learn more about these disorders in order to continue to engage in their factitious disorder. Also, what's interesting is the term pseudologia fantastica. Sorry, not good at pronouncing the Latin terms. But what pseudologia fantastica is basically pathological lying. So individuals who have factitious disorder tend to have a lot of problems with being honest, and they will often be caught in lies, uncontrollable lying. So these individuals may really go on and on about experiences or situations that have actually never happened. Another thing that's unusual about factitious disorder with these patients, they tend to be very accepting of surgery or even uncomfortable procedures. So most patients are going to be a little bit hesitant about wanting surgery. They're not going to want surgery. They're going to want to probably look for other alternatives first. And most patients are not seeking out uncomfortable procedures. So again, this can be a red flag. Individuals with factitious disorder often abuse substances. They particularly will abuse painkillers, and they may engage in pill shopping, meaning they're going to visit multiple doctors and not tell the doctors about one another. These individuals can be very controlling. They can be very attention-seeking. They can become hostile or disruptive if they are not receiving the attention that they want. Another thing that's fascinating here is that factitious disorder patients only produce symptoms when they think they're being watched. In other words, when they're being examined by a physician or a nurse, they will produce the symptoms, but when the nurse or the physician leaves their hospital room, they will then not have the symptoms. So what's kind of interesting is that it is not unusual when factitious disorder is suspected that a camera is placed in the hospital room of the patient to be able to record the patient's behavior throughout the day and evening in order to determine whether they are actually faking their illness. So coming back to this idea of the differential diagnosis, when we are presented with a set of suspicious symptoms, we really want to try to figure out several things. Number one, we want to figure out if the person is producing these symptoms consciously, meaning are they aware that they're doing it? Also related to this is that it's intentional. So there are two types of conscious attempts. One involves secondary gain, again, the financial payoff for faking a medical condition or a disorder or a disease. This is labeled as malingering. So in malingering, the chief goal is to obtain some material reward, like getting days off from work or extra compensation. This is not considered a diagnosis. In contrast, factitious disorder, either Munchausen syndrome imposed on the self or Munchausen's by proxy, occurs for primary gain. So primary gain meaning there's a psychological benefit to the person. So for example, they may have the goal that they want medical attention because they feel neglected or that no one pays attention to them, or to seek sympathy. Now on the other side of the equation, we have unconscious attempts. So this is really important because individuals who have unconscious attempts are also reporting bodily symptoms. Oftentimes the symptoms do not resemble typical medical conditions. But what's different here is that these individuals are experiencing these disorders. They're typically very distressed about it, but they are not intentionally or purposefully producing this. So in another video, I'm going to talk more about somatic symptom disorders, but here there's the main three are somatic symptom disorder, conversion disorder, and illness anxiety disorder, which is formerly known as hypochondriasis. So when we start thinking about separating conscious from unconscious, focusing back on those individuals who are engaging in behavior to purposefully produce what appears to be an illness or an injury in themselves, this is primarily being done for attention seeking, then it would be primary gain. So if we think that the reason the person is harming themselves or producing fake symptoms is because they want attention, we would argue that this is for primary gain, and we would be looking at the disorder as a factitious disorder. In contrast, individuals who are engaging in this behavior, faking an illness or an injury on purpose for secondary gain or for financial incentives, we would label this as malingering, and we would not make a diagnosis. And then third, we have these unconscious attempts, which we'll talk about in another video. Now, you may have heard about factitious disorder imposed on another, otherwise known as Munchausen syndrome by proxy. And this disorder is really, really popular in the movies and soap operas and so on. So in this case, what we tend to see is a very young child who's the victim, and they are the patient in this case. Typically, the patient is quite young. They may be as young as like under 40 months of age, which is about 3.5 years old. Now, you might imagine why the victim would be young, partly because the victim is nonverbal. They are not able to describe or explain to another person what is happening to them. But also, a parent has a lot more control over the bodily functions, the foods, etc. of a very young child. Now, this young child is going to have an unusual history, medical history of very long hospitalizations and or frequent hospitalizations, as well as visits to the emergency room. Unfortunately, when factitious disorder imposed on another is present in a family, we actually may see an increased risk for siblings. So we're often assessing whether the sibling has a history of Munchausen syndrome by proxy or a factitious disorder imposed on another. And even in, this is really awful to say, but even in really extreme cases, we can see death of a sibling, often due to an unexplained illness. These are obviously very significant red flags. The prototypical situation is that the mother is employed in a healthcare profession, and the mother is the person who is engaging in the behavior. She is the person who is producing the symptoms in her child. Oftentimes, the mother also has a diagnosed comorbidity, such as major depressive disorder, histrionic personality disorder, and or borderline personality disorder. And finally, within the situation where there's factitious disorder imposed on another, we tend to see very significant family dysfunction. Now, when we think about Munchausen's by proxy, or we think about factitious disorder produced in another, it's kind of helpful to take a step back and look at how parents might interact with a healthcare system. So if they have a child and their child needs health care, how do parents typically behave? And what the research suggests is that parents typically behave in a way, in a very predictable way, and that this behavior is kind of a U-shaped, inverted U-shaped pattern. So the most common behavior, which is at the top of this arc, or the top of the inverted U, is an appropriate concern. There's appropriate concern and anxiety related to a child's symptoms. So this is the most common presentation. But we can see deviation from this. First of all, you can deviate towards the side where you're not picking up on and not seeking medical care. So this is more towards the side of neglect. Sometimes this is happening because the parent is very careless. For example, children may become injured because they fall. So oftentimes small children can fall out of high chairs, for example, or from being in a position where they shouldn't be. They roll off in and get hurt. So carelessness is one factor. Unfortunately, also we can see indifference. So this is different than carelessness. Indifference means that the parent really doesn't care what happens to the child, so they're not engaging in appropriate parenting to reduce potential risks to the child. So again, we might see more accidents and injuries in that way, or we might see a child who has a medical injury, so let's say a broken arm, in which the parent doesn't seek medical attention. So they allow that broken arm to continue to be broken and not seek care. Now, on the other side, we have the other side of just a very, very high level of engagement in the medical care of the child or healthcare seeking by the parents. So again, in the middle, we have kind of a nice balance between concern and anxiety and the parents being pretty effective. That can start to tip towards more high levels of anxiety, what we call insatiable anxiety, meaning that the parent's anxiety cannot be quelched by medical explanations. They continue to be frantically seeking additional information, often wanting additional tests, for example. And at the very far side of the continuum, we see exaggeration. So exaggeration would be where the parent is reporting that the symptoms are worse than they really are. And finally, as I've already mentioned, we can expect that individuals who are engaging in Munchausen syndrome by proxy are going to be not only exaggerating symptoms, but even producing them. So on the far right of the figure here, we see Munchausen syndrome by proxy, or MSP, but we can also see other names that may be utilized in different systems. So FDP stands for factitious disorder by proxy, or factitious disorder in another. MCA stands for medical child abuse, and MSP stands for Munchausen syndrome by proxy. And PCF stands for pediatric condition falsification. So all of these factors are important to determine whether the child in question is really needing medical care or if there is a feigned condition. And as I mentioned before, unfortunately, the behavior of typically the parent who's engaging in these symptoms or producing these symptoms can be very severe, and they can actually end up killing their child. So what do we know about factitious disorder? So the prognosis of factitious disorder is generally not very good. Remember, prognosis means that what we're looking at is the course of the disorder, how long the disorder lasts, and the likelihood of recovery from the disorder. So the prognosis of factitious disorder actually varies by the subcategory. So men or males who are diagnosed with the psychological subtype of factitious disorder are generally considered to have the worst prognosis. These individuals also engage in high levels of self-harm, where they may be cutting or burning themselves, and also we see high rates of suicide attempts in these individuals. In fact, these individuals can successfully engage in suicide, meaning they complete suicide. They kill themselves. About between 30 and 70% of these patients will do that. So this is a very, very high rate of completed suicide. Now, individuals with this form of factitious disorder, the subtype which is primarily psychological, do not respond well to treatment. In other words, these individuals don't do well in psychotherapy, and it usually is not very good. Now, in contrast, for women, the prognosis is a little bit more variable, and as women get older, the prognosis improves. So if a person who is around a woman who's around age 40 or older, we're going to see much more a better likelihood that they will recover from factitious disorder. The other thing about women is that women will generally accept treatment and engage in treatment at higher rates than do men, which we also think is connected to their recovery rates. There's also the subcategory of the physical the primarily physical complaints, and this subcategory often resolves by itself. And MSBP, which is the Munchausen syndrome by proxy, is a very, very severe and potentially dangerous disorder. There's a very high risk to the child of incredibly severe and sometimes, unfortunately, permanent effects, medical and physical effects on the child. And it's hard to even say this, but almost 1 out of 10 children will die from this disorder because the parents will engage in disorder that actually leads to the child's death. I mentioned at the beginning that there's another disorder called Ganser syndrome, and that is the one subtype of factitious disorder that has a good prognosis. And almost all patients recover within days of developing Ganser syndrome, especially when there's a stressor that seems to be precipitating the onset and that stressor is resolved. So coming back again, one of the key things to make a differential diagnosis for suspicious symptoms is to determine whether the symptoms are due to conscious or unconscious processes. And if there's conscious processes at play, we want to determine whether there's primary or secondary gain. And then after that, we can start to think about whether there's a diagnosis or not. So thank you for listening to this video about malingering and factitious disorder and how we can distinguish the two and make differential diagnoses of these factors from somatic disorders. So in another video, I'll talk more about somatic symptom disorders. Thanks for listening.